Okay, well, good afternoon, everyone, and welcome to Pediatric Teaching. It's good to see so many people online and others watching in other places. So today we've talked this year so far about a variety of topics. We've talked about acute respiratory infection, particularly pneumonia and bronchiolitis, and we've talked about fever, and we've talked about the deteriorating child, and we've talked about an overview of pediatric training. But today I wanted to talk about another general topic, which is pediatric morbidity and mortality auditing. And I think this is very important because apart from learning about different diseases, we also have to learn about quality improvement and how to do that. And pediatric morbidity and mortality auditing can be a basis for quality improvement in all our hospitals. So that's what we'll talk about today. And I hope it will be a relatively short talk, but we can have a discussion afterwards. We'll see how we go. There was a time when, back in the 1990s, when there was not much known about outcomes, especially adverse events, in hospitals throughout the world. In fact, the first studies were done in North America, and they showed, to the surprise and shock of many people, that a lot of patients that were admitted to hospitals suffered adverse events. And these studies were reproduced in many other countries, in Australia and Canada and New Zealand and Scandinavia and other countries in Europe, and they all found similar things. That is that the many patients who were admitted to hospitals suffered adverse events, and many people died unnecessarily in those countries. I certainly recall in the Australian study, it was about 16% of hospitalized patients, mostly adults, suffered some sort of adverse event. So it seemed a remarkably common scenario. But up until about 2000, there was not much known about adverse events in hospital or quality of hospital care for children. And then in the years 2000 to 2010, there was a series of studies that were done in countries, in low and middle income countries throughout the world. And these were very influential studies, I think, because they identified what the common problems of for children in hospitals were. And it was remarkably similar in most countries. And so you can see from this list of countries, there were countries, the top study was throughout Asia, South America, and multiple countries in Asia and South America, and some in Africa, and then a study by Mike English from Kenya, and then studies from the Pacific, particularly the Solomon Islands, and then there were studies from what we now consider to be Central Asia, so the ex-Soviet republics. Those studies were very interesting, and then also from Tanzania, many studies that were done, and they showed rather similar results. And I just want to go through some of the common problems that they identified. These were the common problems in almost all the studies, that in most hospitals in those days, like around 2000, the late 1990s, there was no system of pediatric triage. There was no system by which you could triage a patient as being either very sick or a bit sick or not so sick. There was inadequate assessment by, usually because the healthcare workers weren't trained in how to assess patients. Many children received late treatment for common problems. Many hours went by before they received antibiotics, for example, or some other form of essential treatment. There were inadequate drug supplies, and particularly oxygen supplies. These were big points highlighted in these early studies. There was in many countries, a lack of evidence-based guidelines. Back in the 1990s, not many countries had hospital guidelines for sick children. Of course, they did in Papua New Guinea. We've had the standard treatment book for a long time, but there was not many countries that had anything like that. And some countries had guidelines that dated back to the 1960s, so really very old, 30, 40 years old at times. There was insufficient monitoring of very sick children. There were dangerous intravenous fluid practices that I think everybody's aware of now, giving too much fluid and giving hypotonic solutions. Children who were in hospital received inadequate nutrition, and many children in those days would become malnourished while they're in hospital, even if they weren't malnourished before they came in. There was not a very systematic approach to the care of very low birth weight babies. So even babies that really should survive with good basic neonatal care, those between 1 and 1.5 kilos, many of them died. 2/3 of those children died in those days. There was very little focus on the care of children who had unconsciousness or coma from whatever reason, meningitis or encephalitis, the sorts of things that we do these days to support the care of the comatose patient were not really done. There was, in almost all these studies, most of the healthcare workers, especially in district hospitals in rural areas, had no training since graduation. There was very little evidence of continuing medical education. And there was, in most hospitals, there was no systematic method of reporting outcomes, especially burden of disease data or case fatality rates. There was just nothing like that existed in most hospitals in those days. So these were common problems that were identified by these studies. And from this, I guess, a picture of what quality of hospital care could be was built up. And this is a schematic diagram, really, that comes out of all of these studies that I've mentioned, and it describes the elements of hospital care, good quality hospital care. Now, I won't go through them in detail, and I think you know most of these, but it's interesting to see how many elements there are for good quality hospital care. Of course, first of all, there are a need for staff and human resources, but it's not just having enough staff, it's having systems for training and accreditation and appropriate rostering, so people are rostered night and day shifts and not have more people on days and few on nights, because that's when children were most likely dying. There is a need for supervision, so it's not good enough to have, the youngest, most inexperienced staff on without supervising them. There's a high attrition of staff in those times, and there was clearly a need to have staff retention initiatives and having, as I said, some form of continuing medical education for staff. So it's not just enough to employ staff, but you have to look after them in many ways. The second thing was obviously physical facilities. All hospitals need to have physical facilities, and in many of these studies, the buildings were inadequate, or they needed updating, or there'd been little maintenance, and that hospitals, power and water and sanitation are things that we would take for granted as being necessary for a safe functioning hospital were not adequate in those days. There is a need for drugs, of course, and medicines, but not just the availability of medicines. There has to be systems for procurement and distribution of medicines appropriately, and systems for rational use and medicine safety. All hospitals need some sort of supportive technology, whether it's high-end supportive technology in an intensive care unit, or whether it's just basic supportive technology like oxygen and intravenous fluids and nutrition. But as well as that, there's a need for systems for equipment maintenance, these days for personal protective equipment and for hand hygiene. So these basic supportive technologies were lacking but necessary for good quality hospital care. I mentioned clinical guidelines. In those days, there was almost no, hospital guidelines that were standardized and evidence-based, and there's a need for them and for training resources and a process for updating them. You can't just write a guideline in the 1970s and expect that it will be up to date now. Many countries had limited financing structures for their hospitals. I mean, this is going beyond clinical things, but for many hospitals, their financing was inadequate to meet their needs, and there were barriers to access, as in they charged patients and provided no safety net for the poor. There's some hospitals subsequently have introduced insurance schemes or incentives, but how important it is to have systems whereby the poorest families are still able to access your hospital at no cost. there was, in terms of quality of paediatric care, there is a need not just to be focused on a hospital, but to have a focus outside the hospital. And so to understand what is required for community demand and care seeking, to have communication and referral with smaller health facilities and have transport and access. These are all parts of quality of care. And then there's quality improvement initiatives, and we'll talk a bit more about these today. So outcome reporting, morbidity and mortality meetings like we're going to talk about today, adverse event monitoring, infection control and accreditation. These are all part of quality improvement processes that a good quality hospital has. There are needs for emergency responses, so clinical emergency responses. If you have patients deteriorating within your hospital, as all hospitals do, there's a need for appropriate responses to that, as we've talked about a couple of weeks ago, with monitoring charts and systems to identify the deteriorating patient and escalate the care of those patients. So emergency responses is an important part of quality of paediatric care. And then finally, to have some child-friendly facilities, and I think you can make a big improvement on the quality of paediatric care by having as nicer an environment, as green an environment as you can for children. So family-friendly facilities and child-friendly services and places to play and green spaces are all very important. So these were all elements that were considered an important part of paediatric. So today we were going to talk about guidelines, or about morbidity and mortality auditing. And in a way, morbidity and mortality auditing has become an important element of quality improvement in the last decade. And just a few years ago, the World Health Organization guidelines for pediatric auditing, for morbidity and mortality auditing. And these guidelines, I'm going to go through today some of the elements of good morbidity and mortality auditing, and explain how it can be done with fairly limited resources, and how you can gain a lot from an understanding of morbidity and mortality that you see. WHO suggests that there's 6 steps, and these conceptually are that you identify cases. They're the children, obviously the children who've died or had an adverse event. You collect information. You identify the causes of death. This is important. Just like when you report a death to the coroner, or you report a death to the health department, then you need to identify the exact cause of death, or as close as you can be. You need to identify the modifiable factors, and in some ways that's the most important thing, to identify the factors in the death that were potentially modifiable. You need to make recommendations and about changes that could be made, and you then need to implement those changes or those action plans, make those changes in your facility, in your hospital, and then monitor and evaluate how those changes are implemented. I mean, it's a quality improvement cycle that many of you will be familiar with, but essentially that's what morbidity and mortality processes are about. Some people think it's just about holding a meeting, which is really just at this level and this level, but in fact there's more to it than that, and I'll just explain some of these steps in a bit more detail. So when you're thinking about how to understand the death of a child, I think it's important to have some sort of focus on the timeline, and often we just focus on on what happened in the last day, just when the child died, or what happened to the child as they were arresting, or but I would encourage you to, when you're doing morbidity and mortality auditing, to go back and look, for some cases, look at a timeline. And this is a timeline of a child who, this is a real case. This really happened. So I'll just go through it with you. And it's based on the notion that there are many opportunities to prevent some deaths. There are many opportunities, and it's only when each of those opportunities are missed, when nobody does anything at any particular time, nobody changes anything, that a death occurs. Now, of course, there are some deaths that are completely not preventable, they're unavoidable, but there are other deaths that are avoidable, but they're avoidable at multiple different time points. So here's a timeline of a real case, a 9-month-old girl who was from a remote village, and she was referred for cough and breathing, a common reason for referral. She was unvaccinated. She was from a remote village and unvaccinated. She was brought by a mother to the district hospital late at night, and at that stage was unable to feed, and she had severe chest indrawing. So already there are some red flags there. She's got unable to feed, and she's got severe chest indrawing. You might think she's got severe pneumonia. Now, the doctor was unavailable at that district hospital overnight, but she was seen by the nurses, and they treated her as best as they could with oral amoxicillin. They didn't have any oxygen at the hospital. The cylinder was empty, and there was no delivery of oxygen to the hospital in the last week. This is, again, a real case. I'm sure for many of you, this type of scenario would be familiar to you in referrals from rural hospitals. In the morning, because there was no oxygen at the district hospital. In the morning, because there was no oxygen in the district hospital, she was referred to a provincial hospital. And because there was no fuel for the ambulance from the hospital, she travelled by bus with her mother. So she was carried by her mother in the bus, a 2-hour journey to the referral hospital. When she arrived at the referral hospital, this was at 9 o'clock in the morning, her heart rate was 190. She was cyanosed, her respiratory rate was 70. She had no pulse. There was no pulse oximeter in the emergency department, but clearly she was unwell. And she was taken to the children's ward at 9:45, and then at 10 o'clock she arrested and died at 10 o'clock from hypoxemia. And I think you can see from that timeline that there were many opportunities in which the outcome for this child might have been different if somebody had been able to do something different. And this is called the holes in the Swiss cheese. It means that there are potentially lots of opportunities where there could have been defences that might have prevented this child's death, but because none of them were in place, none of these strategies were in place, the worst thing happened. So this is what we sometimes refer to as a root cause analysis, where you go back over time and try to understand all the different steps that led up to the child dying. And the reason for that is not to blame people, but to try to identify what strategies could be put in place to prevent such an event happening again. I wanted to just briefly talk about a couple of audit studies of audit that at least they taught me a lot about this process. And quite some time ago now, we undertook a 2-year study looking at all the deaths in Goroka Hospital, and this was introducing a morbidity and mortality process that happened every week or every second week, and we discussed death. We discussed the clinical and the bacteriological and the laboratory data where that was available, and we reached a consensus as to the causes of death and whether there were any potentially avoidable factors. The notion of potentially avoidable is important. We're not saying that the death was necessarily avoidable. We're not saying that they definitely were avoidable. They were potentially avoidable. That is, if some changes could be made, then maybe the circumstances could be avoidable. The important part of this was that it was a meeting. It wasn't just a study. It was a meeting where all the department staff, the nurses, the doctors, the pharmacists, anyone else who wanted to come could attend. And there was free discussion, and it was an opportunity for teaching. It had an educational aspect of it too. And we found that in 177 of over 300 deaths, there were avoidable factors, potentially avoidable factors. And I wanted to go through a few of those avoidable factors because I think it's important to understand how to consider what factors might be avoidable. There were factors at multiple levels, at a community level, in terms of primary preventative health services, like public health services, in terms of primary curative health services, and errors that were made or problems that arose at the referral hospital. So, for example, delayed presentation of seriously ill children, or child neglect or abandonment, or failure to access maternal care. They're all issues at a community level. Vaccine preventable diseases, a failure of disease screening programs, or if the health facility was closed or out of stock of basic drugs. So all these things at a primary curative health services, at a health centre or district hospital level, and then common problems at a referral hospital, problems in obstetric care or drug prescribing, or nosocomial infections that led to death, or oxygen problems, or the failure to give standard basic treatment. So again, it's not saying that all of these deaths were avoidable or could easily have been prevented. They highlighted gaps or problems that we needed to fix up. A similar study was done by the team in the Solomon Islands, and they reported 33 child death review meetings over a year, and that covered 66 neonatal and child deaths. And I think just to summarise the common areas for improvement, we're often about communication, and I think we find that increasingly now, especially in the modern era. Many problems arise because of lack of communication because handovers are not clear enough, because referrals are not made in the right promptly enough, because people don't respond to referrals, communication on ward rounds, etc. All of these many problems arise from inadequate, imprecise communication. There were problems of clinical assessment and treatment, some that I've mentioned before. The availability of laboratory tests, antenatal clinic attendance, and then just for many children who had more critical care needs, the equipment for high dependency neonatal and pediatric care was a problem. So many of these changes were recommended in all of these meetings, but what the team in the Solomon Islands identified clearly was that it wasn't enough to hold meetings, but actually have a quality improvement team to implement those changes. And I think that's something that's very important for all hospitals. The team doesn't have to be very large. It can be just a team of a doctor and a nurse, the doctor and the nurse in charge of the hospital, or it can be more. It can be a larger team that has other people, but there has to be more than one person who's responsible for the implementation of recommendations. It should be a quality improvement team. I think that having been involved in such audit meetings for many decades, I think there are some principles, and I want to just go through some of the principles of having successful audit that helps your hospital. The first one is to hold regular meetings. People need to know that these meetings are going to happen, not that there needs to be some consistency for your staff. They need to know that they're at a regular time every week or every month. The meetings have to be confidential. You should encourage, I think, open discussion inside the meeting. Lots of discussion inside the meeting, but no discussion of specific cases outside. The communication of general information about recommendations, that's important, but not a discussion of the cases themselves outside. But inside the meeting, I think an open and robust discussion is very important about the case. The attendance should be voluntary, but it should strongly be encouraged that all staff should attend, and they should be welcomed. All clinical staff, especially nurses, doctors, registrars, residents, they should all be encouraged to attend. The atmosphere should be entirely non-blameful and non-threatening. It's very important to be welcoming of staff and that they can come along knowing that they're not going to be blamed for some error that happened. Very important. Non-blameful is very important. I found it useful when chairing such meetings to be open about declaring my own failings sometimes, and this can put junior staff at ease, because if the leader is saying how he or she feels they could have done better, then they'll feel more comfortable about a discussion where where there are lessons to be learned. I think these audit meetings should have a strong educational function. It's not just about identifying problems and trying to fix them, but trying to be educational at the same time. You should take every opportunity to teach on subjects that arise when they're relevant to quality of care and how you do things in the hospital. I think that you have to have a team approach to solving problems. The chair of the meeting should get a wide spectrum of views on the cause and the prevention of adverse events. It shouldn't be just one person makes the decisions. I think it's important to be respectful and acknowledge all healthcare workers' efforts to try to understand. If you're a healthcare worker and you're involved in the care of a child who's died, you often feel very bad, and it's important to try to understand how your staff are feeling if they've been caring for a child who's died. They might think it's their fault, or that other people are blaming them in some ways, and it's really important that you make sure they don't think that no one thinks it's their fault. I think sometimes we focus very much on specific things and we drill down on specific things, but it's important to take the discussion away from specific things like a specific error or problem that might have arisen to something more general. How can we fix up a general issue that might prevent the specific problem arising again? When you're going through such audit meetings, you should look for common patterns of avoidable events. You shouldn't react to one single random event or random mistake. I think that's too reactionary. We've got a lot of common patterns of avoidable events that in our hospitals, and we should try to identify them and fix up the bigger things rather than the minutiae. Very, very important not to single out any individuals for blame. The team leader should identify and emphasize how we could do better, not one individual. That's very important. And when you, as I mentioned with the study I showed from Goroka, very important to consider the entire health system when trying to understand the avoidable factors in deaths, not just at what happens at a hospital, but what other changes may be needed in the community or in health centres, in primary care, etc. I think in an audit meeting, it's important also, they tend to focus on deaths, but don't forget the things that went right. If 5% of the children in your hospital die, 5% of all admissions die, then 95% of children survive to discharge and are well, and most of them live happily ever after. And it's very important to emphasize that survival rate and all the things that went well. I think instead of going through repeatedly identifying problems that you can't fix, try to focus on problems that you can fix, feasible and affordable changes in clinical practice, things that we can fix up rather than things that we can't, or things that need a lot of resources or more funding. Try to focus on the things that you can fix up with not much additional funding. You should have clear resolutions about action items. That's important from any meeting, and be clear about who'll do them. Remember, I said you need to have a quality improvement team, not one person who runs the meeting and then is responsible for fixing all the problems up. The quality improvement team should do that. And don't forget to cycle back to the previous month's audit resolutions and follow up to determine if these were carried out. It's very important to complete that quality improvement cycle. This is a bit different, but I often consider auditing, morbidity and mortality auditing, something to do with child's rights. It's an obligation to do justice to a life. A child has lived and has died, and we should, be trying to do justice to that life. It's not just a mechanical process about tools and outcomes and systems. It's fundamentally a human process. And our human relationships to our staff and the families involved are very important. I think the audit can actually help families. If families know that the audit is going to review their child's death, then it helps them to know that everything has been done, to know their child's life was valued and the death was taken seriously, and to know that we committed to learning from the death. Now, in most cases, there won't be anything that could have been done differently. And that's important for families to understand. And even if the audit does identify some problems that could have been done differently, it doesn't mean that child's death was preventable, or that any mistake was made. It's just a matter of learning how to do things a little better. But I think it can be very important for families to know that the child's death is taken seriously and is reviewed by the audit processes in the hospital. On the Paediatric Society website, there are the tools for child death review meetings, and these tools are similar to those from the WHO child death review guidelines that I mentioned before. In fact, they're the same ones, and you can look them up at various times. There's a description of how to do morbidity and mortality reviews. There's a register form. There's a child death reporting form. So this is the WHO's child death review form. It's a simple form. You can adjust it as you like, but it just goes through some demographics of the child, the time of death, the area where they came from, the location of death, the number of days the child was sick, the date of hospital admission, and then the story. And this is an important thing. If you're preparing for a morbidity and mortality audit meeting, then the story is the most important thing. It's not so much the diagnosis, but trying to understand the story, something about the timelines, something about the events that happened, whether the child was referred or not, has the child recently been discharged as an inpatient, and then there's some questions, specific questions about neonatal deaths, and then some questions about in the neonate, the vaccine status, the location of birth, their nutritional status, investigations, the diagnoses that were made. So this is any pediatric death, the diagnoses that were made, the sort of social or environmental factors, the treatments the child received, whether any complications of treatment, or any treatments you wanted to give not available at the time. And then perhaps the most important part, apart from the stories, was the child's death possibly avoidable? And you can just describe how the child's death might have been avoidable by something improved at home or the community, or at primary care, or within the referral system, or at the hospital. And it doesn't need to be in much detail, but this is what you should be able to do by the end of the audit meeting. And oftentimes there'll be no avoidable factors, and that's fine, but that's what the meeting should be about telling the story of the child's illness and their death, and then trying to understand if there are any potentially avoidable factors or possibly avoidable factors. WHO has a standardized list of diagnoses that are consistent with their classification system and ICD-10 coding systems, and also consistent with our pediatric hospital reporting program, but that's also on the website and in the guidebook that WHO has. I just want to go back to this case that I mentioned before, because I hope you'll be able to see from this sort of understanding the story of what happened to this child, the sorts of things that could be put in place that might make a difference. And at an audit meeting, you would start to think about those things. So I won't go through the story again, but there's a lot of things that could have made a difference. So having oxygen and pulse oximetry in the children's emergency department when the child arrived, but having monitoring charts. This is in the referring hospital. Perhaps more importantly, addressing the oxygen or drug availability and the staffing at the district hospital, understanding why the child was not vaccinated in the village, and then, as I said, having a quality improvement team to enact some recommendations. Now, you might have thought of other recommendations that would come from this particular story about this child who presented to the district hospital and wasn't able to get oxygen and then was transferred on a bus to the hospital. But you'll know similar stories of children who've died and the potentially avoidable factors that could come into play there. And I just encourage you, if you're doing morbidity and mortality auditings, to outline the story, to think something of the timeline, and to be identifying the potentially avoidable factors and the feasible recommendations that you could put in place to prevent those things happening again. So that's really all I want to say about morbidity and mortality auditing, but I'm happy to answer any questions that you might have at any stage. Thanks.